Hi, everyone, and welcome to today's GlomCon. I'm Dia Wagas back in Houston. We're at the top of the hour. I'd like to thank everyone for joining. We're really excited about today's session. Start off the new year with our collaboration with NephCure. So today's conference is Practical Pearls for Trial Recruitment, Perspective from two investigators and a patient. So today we have panelists with us, Dr. Jonathan Hogan from the University of Pennsylvania. So Dr. Hogan is a nephrologist, completed his residency at the University of Pennsylvania and fellowship in nephrology at New York Presbyterian Columbia University Medical Center. He serves as the clinical director for the Penn Glomerular Disease Center and is the assistant professor of medicine at Hospital University of Pennsylvania. His clinical and research interests are in glomerular diseases and onconephrology. Our other panelist is Dr. Suneel Udani. Dr. Udani completed his undergraduate master's of public health and medical school at Northwestern, went on to do his internal medicine training at the University of Chicago and the University of Pittsburgh, served as a chief medical resident at Cook County, and then returned to the University of Chicago for his fellowship in nephrology. Dr. Udani is the author of multiple peer-reviewed journal articles and has presented his research at national conferences and the author of multiple textbook chapters on diagnosis and management of kidney diseases. Our patient joining us today is Jenn Trunk. Jenn went to undergrad at Purdue University to study engineering and has spent most of her career as an automation engineer working for food and pharma companies. She was diagnosed with FSGS over 15 years ago, and in that time period has spent time on peritoneal dialysis, home nocturnal hemodialysis. She has undergone kidney transplantation, experienced relapse of her kidney disease, and has participated in clinical trials. Jenn also volunteers for NephCure and the National Kidney Foundation and has spent time as a speaker in various groups. And we're very excited to have her and her give us insight on this very important topic. Today, moderating the session, we have Dr. Barbara Gillespie. Dr. Gillespie completed her residency in internal medicine at the University of North Carolina and her nephrology fellowship at Duke University. She's currently vice president at Covance Global CRO, where she is the therapeutic head of nephrology and continues to support sponsors on CKD, drug, and renal device development. She is also an adjunct professor at the University of North Carolina, Division of Nephrology and Hypertension. Barbara is currently working on the board of directors at the Kidney Health Initiative and is a member of several work groups. And our other co-moderator today is Kristin Hood. Kristin served as an assistant professor of nursing at Wayland Baptist University in the Bachelor of Science Nursing program prior to her joining NephCure. She teaches in her role in NephCure as the director of clinical outreach, where she focuses on patients, families, and advocates within our community. Kristin had earned her Bachelor of Arts in Southwestern and completed a Bachelor of Science of Nursing at the University of Texas Health Science Center and went on to earn a master's in nursing. She's now currently attending Bryan Health Science Center, completing her doctorate in nursing education as she works as, like I said, as in clinical outreach as the director for NephCure. So we're excited to have all of those participants with us today. So to go a little bit more into our collaboration with NephCure, NephCure is Kidney International's mission is to accelerate research for effective treatments in rare forms of nephrotic syndrome and provide education and support to improve the lives of those affected by protein spilling kidney diseases. Why have we collaborated with NephCure and GlomCon together is to bring awareness to clinical trial participation as an option for patients who have glomerular diseases, increase awareness from both patients, providers in academics and private practice to scientific advancements and related study opportunities. And then also NephCure and GlomCon have allowed both of us to provide resources about glomerular diseases and trial opportunities. And we'll talk a little bit more about the Kidney Health Gateway a little later in the talk and show you guys how that works. So with that, today, our goal is really to give you insight into patient recruitment and retention for glomerular disease trials. We have Dr. Hogan joining us, who is in academics, and Dr. Udani, who is in private practice, to both share their experiences and then most importantly, understand the perspective from a patient. And so with that, I will turn it over to Kristin.
Thank you, Dia. Good morning, everyone. My name is Kristen Hood. Dia, thanks for that intro. Just to get us started, I'd like to talk just very briefly a little bit on the Kidney Health Gateway. Kidney Health Gateway was or is a very patient-friendly clinical trial matching site. We like to call it the match.com of clinical trials, is the best way to put it. So kidneyhealthgateway.com is friendly for patients. They can, you can see the landing page here on your screen. Patients can go onto the website. They can answer a few questions regarding their diagnosis. They can even enter in a few lab values, and based on their answers, they will be matched to clinical trials in their area. So it is zip code friendly. We have also added a physician portal so that you can go in as a physician and filter clinical trial sites by your zip code. You can do this with your patient in the room if you use like an iPad or laptop. You can show them in your clinic, or you can encourage them to do this on their own. What we have found, Dia, you can go on to the next slide. What we have found is that patients, unfortunately, are not told of clinical trials enough during their visits with their physicians when we have polled them. And I'll show you a slide next that demonstrates that. But from the feedback and the traffic that we get into kidneyhealthgateway.com, we know that patients are interested. They want to hear more about what is open and what are their options that are out there. They know that there are currently no FDA approved medical or medicine treatments for their conditions, and they are wanting different options. So like I said, you can go into this site, you can filter by zip code. You can go on to the next slide. You can, on the welcome screen, you just say, are you a patient? Are you a patient caregiver? Are you a physician? Are you a researcher? That sort of thing. And if patients are just wanting some more general information, they can fill out this form that just gives us a little bit more information. You can do this as well, and you will be subscribing to some newsletters that are sent out around clinical trials. You can go on to the next one. Okay. I think this is Barb, right?
Yes. Hi, everyone. And Kristen, can you hear me? Okay, great. So sorry for the darkness here. I didn't realize I'm in my building illegally today. They've turned off the lights in my office. Anyway, welcome everyone on a Sunday. It's great to have you guys here, and a special thanks to Dia. She's in the middle of rounding, although she looks calm and cool there. So thanks, Dia, for all the efforts behind the scene. Okay, really excited for this talk today. I work at a contract research organization as my day job. And so I work a lot with sponsors and talk to PIs. And really, I know we're used to talking about actual diseases and more science in these meetings, but today is meant to be a really good practical talk, and really want to hear from both of our PIs their thoughts on making it easier to recruit patients and keep them in trials, retain them, and also from Jenn to hear what her experience has been, and to kind of just hear a little bit back and forth. So I want to start with a reminder of the executive order signed now 18 months ago. And this was a game changer. We're finally highlighting the importance of promoting the treatment of care for kidney health and not kidney failure. And so I'll just focus on the third goal there at the bottom, is to reduce the number of Americans developing kidney failure by 25% by the year 2030. So that's only 9 years away now. And the American Association of Kidney Patients has termed this the decade of the kidney, and it absolutely is, because to get there, we need more data from research and trials so that we can slow the progression of CKD. We are in the middle of a great momentum right now of the last year or so of some new agents coming out for diabetic kidney disease and getting label extensions, but we really need to focus on glomerular disease. I believe FSGS was first described nearly 97 years ago. IgA nephropathy was first described, I want to say 50-ish years ago, and still we've got no approved drugs for these diseases. Next slide, please. And so I am thrilled to learn of some new recommendations in black and white. These are the Cadigo guidelines on glomerular disease. This is from the public draft from last summer, but I've communicated with Dr. Barrett and he's happy to help share some of the news. And that is chapters 1 and 2, where they are endorsing the idea that trial participation is an option for clinical cares. And now again, it's in black and white and actually recommended in our guidelines. So in chapter 1 of the guideline, you can see the practice point right there. Patients with GN should be offered participation in a disease registry and clinical trial whenever available. And then chapter 2, specifically for IgA nephropathy, all patients who remain at high risk of progressive CKD despite maximal supportive care and persistent proteinuria after RAS inhibition should be offered the opportunity to take part in a trial. So those are the words, and here's the algorithm. So I don't know if any fellows are on the line, but I know we're all used to Googling up to date and Cadigo when we're treating patients, in particular for IgA nephropathy, right there in the middle, consider enrollment in a clinical trial, even before considering a trial of corticosteroids. So for me, this is really exciting. It really endorses the work that a lot of us are doing, and ultimately this benefits the patient. A little side note on clinical trials, we're giving a KHI webinar on Thursday, the 14th. The FDA has come out with a guidance on enhancing the diversity of clinical trial populations. And in that talk, we're going to talk about the guidance, and we're going to talk about how this is applicable to some glomerular diseases, increasing the amount of Asian Americans in our IgA trials. Obviously, in the US, they're one of the most least represented populations in clinical trials. And of course, there are other areas like lupus nephritis and FSGS where diversity really matters. Okay, next slide. And I'll echo what Kristen has said, to really embrace this idea and the reality that trial participation is an option for care in kidney disease, we really need to shift the culture. There's 2 pieces of data up here, and this was, I took this about 2 years ago, but basically, we healthcare professionals are not doing a good enough job. Nearly 70% of the time, we are not mentioning trials to our patients. And when I see patients at UNC, and I precept fellows clinic, after we go through the plan, it's a simple question. Are you interested in a clinical trial? If the answer is yes, then we can help that conversation by bringing the study coordinator in. If the answer is no, we respect that and understand that, but it's still something for them to even think about. And when I think about Trial Finder, maybe that's something, Kristen, that we should be, an iPad or computer in the waiting room so patients can play around with it. So by the time they actually get to the appointment, they already have 2 or 3 trials in mind. And I really encourage everyone to go on Trial Finder because I did it when it first came out as pretending to be a GN patient. And for one disease, when I put in my disease was FSGS, I got a trial from UNC listed. When I put in another disease for IgA nephropathy, Duke came up. So using your zip code and matching you to the in proximity to the PI that's doing a trial for your disease is really helpful. And so here, I don't know if any of you've seen these buttons, ask me about a clinical trial, similar to the ubiquitous pink ribbons for breast cancer, or the way I know about blood donation is people wearing the stickers after they do it. It's just grassroots efforts, wearing this on your white coat. Patients will ask you, oh, what's that about? Ultimately, we can make the buttons for patients that say, I participate in a clinical trial. Because again, I think if a patient's wearing this in the waiting room, it might prompt another patient to ask them and really get that conversation started. Okay, so let's move on to the next slide. And really thrilled to be speaking with Suneel and John today and hear their perspectives. They both run clinical trials. I imagine most of their trials are in glomerular disease. And so I don't know if their study coordinators are on the line today also, but really looking forward to their feedback. So we devised a set of questions, and I'm going to go ahead and ask a question on a couple of different topics that you see listed here, and we'll just leave it to Suneel and John to open up the conversation and answer the questions. Okay, so the first question I have is about increasing awareness of clinical trials. How do you make patients aware of trials at your site and elsewhere, and what works? When I speak to sponsors, we start with a wide list of even considering radio and TV ads, but I don't really know what works best at both an academic practice and at a private practice. So Suneel, why don't we start with you?
Sure. Firstly, just thank you for the invitation to join. I think it's a very important topic, as you guys already outlined, and hopefully this can be helpful for others, and we can ultimately increase our clinical trial execution and achieve more advancements. Now, in terms of increasing awareness, I think it's definitely a work in progress. We have done it through a few ways, really conventional ways, and I think that if there's innovation in this area, we should adopt it. We have clinical trials listed on our practice website. Anytime a clinical trial is opened, there is an email sent to the widespread physician network, and so our practice consists of about 100 nephrologists, as well as we have monthly newsletters that go on, and then it really becomes an issue of kind of knocking on doors. And so as we ask the PIs, myself included, to reach out to people directly, say, okay, you got the email, that you saw what it's about, what can I help with? Here's the best way to reach me to talk through it. And that's from the provider side. From the patient side, I think that's where we're lacking. And I'd love to hear Jenn's perspective on this. And like I said, we have it on our practice website, but I don't know that it's that effective at reaching the population we want. I think partnering with local societies such as NephCure and the IgA Foundation in terms of making them aware, as well as NKFI or National Kidney Foundation of Illinois, because I know they also connect with patients more. Connecting with them in terms of making them aware, that seems to be the best way for us to ultimately increase awareness, but there's still a lot of work to be done.
Okay, great. And I hadn't thought about making more use of the local NKF chapter. So NKF Illinois, and we each have a chapter in most of our states, I'd assume. So that's a great thought. Okay, John, over to you.
Yeah, I'd like to echo Suneel in thanking both GlomCon and NephCure for the invitation to be a part of this webinar today. I really appreciate it. I think that, as Suneel is kind of alluding to, there's kind of a bit of a culture shift that needs to occur on the local institutional or practice level, and then the regional level, and then the national level. And each practice and each center, I think, is going to be very individual as to how, what challenges and opportunities and what their culture has been surrounding clinical trials and awareness, and also adopting new strategies. And of course, the main component, as Suneel alluded to also, is being patient communities and having them having an integration of all of these key stakeholders into awareness. So we do have our trials listed on our website. We have a central folder now. We've adapted to sort of Microsoft Teams now that everybody is, I don't get paid by Microsoft to say that, but we're using Microsoft Teams for our division resources now. So we're trying to experiment with various ways to keep our physicians and our providers at least aware and engaged, because as you imagine, if anybody was to come to you during the course of a really busy day and say, hey, do you want to be a part of this trial for polycystic kidney disease, which is really not part of my expertise, fitting that in is very difficult. So it sort of needs to become part of the fabric of the institution. And so institutionally, we've been experimenting, and I think we're slowly making ground, but it does take a long time, and it takes a real divisional commitment. But I would say that divisionally, we've done this through our regular education during our renal grand rounds, and kind of continuing to put the pressure on the division to understand what's going on, at least within our glomerular clinical trials. Regionally, we have a pretty good referral stream from many regional nephrology practices. And so we do have our yearly CME meeting where we really do highlight a lot of our clinical trials. We are trying to develop a way that we can send out regular updates to those groups. This has to be IRB approved, which again, it's kind of getting into that nuts and bolts, but you can't just arbitrarily send out information at our institution without getting IRB approval. So having regular updates sent to those referral streams and having the buy-in from the community is essential, right? Because these are rare diseases. We can't expect as an academic institution to be seeing actually the majority of these. The majority of our patients for clinical trials come from referrals. And so, understanding that landscape and figuring out how to get on people's radars consistently is important. Obviously, having accessibility to our referring physicians, right? It's all about accessibility. So if they have somebody they can text immediately and get an answer within a few minutes, then that keeps the momentum. If there's an email or sort of a central place where it goes to, like, the general clinic, then that's a setup for failure, in my opinion, because you really need to seize those opportunities for these rare diseases. So obviously contacting the physicians directly, we try to get people plugged in immediately. And then on the national level, I think this is probably a bit of a broader discussion, but it takes into account all of these stakeholders, and most importantly, the patient community stakeholders that again, Jenn maybe can speak to. But those are some of the things that we've been doing, but clearly there's been kind of a paradigm shift. And I do think that in the last 5 years that you can see the entire nephrology community starting, really mobilizing around clinical trials. It's everywhere. You go to any national meeting, you talk about glomerular disease, and the first thing that people say is, what clinical trials? And even the incorporation into the guidelines is really, it's really an attempt at a cultural shift. And I think just recognizing that and understanding that will take time, and that understanding your local institution, how to promote that in your region, is important for success in making headway.
So I love, oh, go ahead, Sunil.
I just wanted to add one other, a lot of what Jonathan said, I'd like to echo, but also just regionally, we're in a private practice in Chicago. And so been trying to also, build a network within Chicago and wherever city you're in, to reach out to other people that are doing the trials in the area, so that we all know what other trials are available. So that if a patient is not interested in the trial I'm running, but they have an interest in a trial that a colleague is running, a few cities down, there's usually people will be willing to travel for that. And I think that's the other thing, is that we are kind of in silos, at least in the community. And so trying to build a tighter network of that, I think can also help to sort of spread the gospel.
Yeah.
So I would say, with the travel involved, maybe some non-investigators think, well, the academic institution doing the trial is too far away, that it's too much. But what I hope they realize is a lot of sponsors are willing to pay for travel, especially for rare diseases like glomerular disease. They recognize that people are driving 2 to 3 hours. And so, reimbursement for travel, hotel stays, should not be an issue for our GD trials. And so that's a message that I want the clinicians, the non-investigators, to understand. Quick question, John, you mentioned accessibility and texting. So there's an immediate kind of connection. Were you referring to texting other physicians for referrals or texting patients?
No, what I was referring to is that, in the course of a busy day, if it comes to your mind as a referring physician that you want to know what clinical trials may be available, or there's a patient in your office who is potentially a candidate, but you're not clear on the landscape, that, obviously the gateway is a key resource, but it's not one resource dependent, right? It's kind of and I think that accessibility to the places that are doing clinical trials, so that you can get a quick answer and get the patient connected with the appropriate resources, whatever that may be, a clinical trial center or whatever, or me referring to Kidney Gateway if I'm not running anything, is important. And I think sort of just understanding that the community will not entirely mobilize around this movement, and so everybody's a little different. And so what I mean by texting is that when I have referring physicians, the key is accessibility, right? So if they can get a hold of me for a clinical question or a question about research, and I can get back to them quickly, then that is a recipe for success in my opinion. It's just like anything else, right? You want a roofer, you want a mechanic, you want somebody to pick up the phone, right? That's the first thing. If they pick up the phone and you like them, accessibility and affability, then you're in a position for success. So I think just having that connection between our community for us being a resource for both clinical care and for research is essential. And so what I mean is that we're in regular contact with our referring physicians, because again, we cannot. I would not have a job without referring physicians, right? These are rare diseases. We're not going to be able to concentrate them at any one center.
Yeah, completely agree. I mean, relationship building is so key to advancing the science, whether it's people working on grants or referring patients for trials. So really good point. Okay, let's move on to the next question. So in terms of education, what do you think what are the tools you think that are most effective in helping patients understand the rationale and the goals of these studies? And Jen, feel free to jump in at any point if you have a quick reaction to what we're saying. And so, we've all worked with patients in work groups, and there are kind of activated patients where you're almost preaching to the choir, but then there's that bigger pot of patients where we're trying to reach and kind of overcome some of the fears and appropriate distrusts, for example, in certain populations. But what have you seen work in your patient populations at your sites? Sunil?
So, for us, I think that, once we get a patient that's interested and they come in to get more information, I think, just going through the context of where we are in this disease state, whether it's IgA nephropathy or FSGS, why we're doing the trial, how do we get to this point? Recently with a trial on IgA nephropathy, I do walk patients through kind of how we ended up here, and why clinical trials are now part of the guidelines, and what's the rationale. I think they appreciate it. I think they understand that they are part of the scientific process then. And they also understand that, we're never going to get further without, trials succeeding, or at least being carried out to completion, and their participation is key. And I also think that is the point that I like to emphasize very clearly, is that this trial may not be helping you. This is meant to help. It may, and we hope it will. But ultimately, this trial is meant to help perhaps you in a year or two from now, or the many people that come after you. And it's truly a selfless act. And I think that we have to be honest about that in terms of what we're offering. Yes, they may have closer monitoring because of the being participating in the trial, but in terms of people coming in, if they're expecting that they're going to get the new blockbuster drug, I have to be very clear that we're not sure what you're getting, and we're going to make sure you're safe. But ultimately, without this, we'll never get any better. So I think that once going through that process, I think patients really appreciate that. They understand why we're doing it. They see why we're passionate about it, and in my experience, that has been successful in terms of helping them, stay involved.
Yeah, I would say I agree. I think actually when we were going through the exercise of kind of thinking about these questions over the week, I think this is probably the one that is most, in at least I will speak personally from my blind spot, is coming up with a structured way of understanding from the patient perspective what is effective. And so I think, I can tell you briefly that we have lots of patients enrolled in registry type studies, and we try to keep them appraised of what's available, and we do screen our patients, and that comes up later in our discussion, and try to keep that group of patients engaged. But clearly, with social media and with patient advocacy groups like the IgA Nephropathy Foundation and NephCure, these are tools that I think I can't say that I can answer accurately that I really do have a good feel, because these are rare diseases and patients are all over the place. So I only know what I know. So maybe Jen can chime in a little bit about from your perspective, what's been effective.
Yeah, I totally agree. Why don't we, Kristen, why don't you give a quick introduction to Jen? Let's kind of jump around here, because I think it's really important to hear her voice now.
Yeah, it is my pleasure to introduce to you Jenn Trunk. Like in the intro that Dia gave, she's been an FSGS patient since 2005. And Jen, you have participated in more than one clinical trial. Can you tell us a little bit about, your experience and kind of the conversation around the education and what has been most effective? When you went to your doctor, did they talk to you about clinical trials? Did they give you educational resources about clinical trials?
No, sadly, no. Very early on in my disease, I just had kind of a general nephrologist. I was living in Indiana at the time, and this was very early on in the disease. And 15 years ago, there was very little information on the internet about any of this. So you're kind of just at the mercy of the doctor that you have. And if they don't have any research background,
nephrology,
you're not going to get any clinical trial information. I have brought clinical trials to doctors, and they were not exactly excited about the thought, excuse me, of me trying the clinical trial. They were more worried that it would cause harm. That was, that was in the past. I'm not saying that's a current thing that I face now. I'm a dialysis patient now. So for the last 5 years, I'm not eligible for any clinical trials. But the ones that I have participated in, I have found myself, I've pursued outside of my own doctor, but I realize I'm kind of an outlier in that regard. And that's how it's happened for me. And at the time, I don't know if I would have been more comfortable participating in a clinical trial if I hadn't already exhausted all of my therapeutic options. I went out of remission with my FSGS in 2009, and I never went into remission again. So it was very easy for me to be willing to participate in the clinical trial for some of the reasons you have spoken about. I understood that it was for the greater good. Sorry, my dogs are going to keep coming in and out of this room several times because, well, they love me. Excuse me. But I knew that it was for the greater good, and I knew that there wasn't anything else I could do, so I might as well. This was a way for me to still stay involved too, and felt like the experience that I was having had some meaning. So that is kind of how, in my mind, I approached it. Now, I know there's a lot of different options now. I mean, like you said, Kristen, I'm involved with NephCure, the National Kidney Foundation. They both, NephCure more so than the NKF, I feel, has tried to do focus incredibly so on clinical trials to get people involved. I get emails about them. So from my perspective, and the patients that are involved in NephCure, I think clinical trials are more front of mind now than they ever were before.
Yeah. I think from my experience talking with patients who, part of one of the main jobs of my role at NephCure is really promoting and educating patients around all aspects of their rare disease. But we have obviously had a big focus on clinical trials in the more recent years. And, one of the very, I would challenge the physicians is to really find out what does clinical trial, what does that term mean to the patient? I think if you understand what does that mean to them, well, first of all, they're going to have very different answers, but I think that might also guide you in where and what kind of resources and education do they need. There are some that say, it's hope for me. Some will say, well, that's just an experiment like in a laboratory. Some will, it's a wide variety of what the answer will be. But I think if you ask that question, are you interested in a clinical trial? Yes or no? Well, what does a clinical trial mean to you? What is that term? I think that might really highlight and enlighten where they stand and maybe where the education needs to reside.
Yeah, and there's actually been a fair amount of work that's done. There's a group in Boston called, it's like CISPR, the Institute of Clinical Research, and when they surveyed 12,000 patients a few years ago, and I can share these slides separately, but a lot of good data on exactly what you're getting at, Kristen, trying to understand what the patient's hearing and address certain parts of it. So Jenn, thanks for your thoughts. I just want to say that, as a dialysis patient, I'm wondering if your nephrologists have offered you trial participation in a dialysis study, whether it's for secondary hyperparathyroidism or anemia, or, not anymore focused on FSGS, but kind of general dialysis trials.
No. In my experience with dialysis physicians, they're just focused on getting you stable. Yeah. There doesn't feel to me, and I've had a few dialysis physicians in my time. There doesn't feel like there's any focus on anything outside of dialysis. So I think a lot of dialysis physicians are, in regards to the anemia thing. I have anemia. This is something I struggle with the whole time, but my doctor's never brought, and I brought studies to her, and she is like, no, that won't work for you, kind of all the time, without really reading it. I think she's just really resistant to it. She doesn't want, especially if a patient is stable, which I am now, she doesn't want to throw anything in there that might rock that boat. Now that doesn't mean that I wouldn't do it anyway, because I'm a bit stubborn about some of those things, but my personal one right now wouldn't bring anything to me, no.
Yeah, a little more difficult with dialysis trials, just because if that particular dialysis unit is not participating, it's not as easy to refer. Like we can refer to, Dr. Udani and Hogan's practices. But I will kind of promote the idea that if your dialysis unit is part of one of the chains like Fresenius, DaVita, US Renal Care, I know all of them have some interest in promoting clinical trials. And so I think if the central offices hear this kind of interest and even demand from dialysis patients, maybe they could start to trickle down and encourage more of their clinicians to be part of trials. Because you go back to the executive order when that came out 18 months ago. I attended a meeting with Fresenius and they said, we can't just focus on dialysis. We do have to be part of this effort to prevent our patients progressing. So that's a culture shift as well, maybe a bit longer because of the logistics, but I do hope, in the future, we'll see more dialysis practitioners also participating. So I just want to say, Dia, that I can't, my cursor is lost and I can't open the chat function. So if there's stuff coming up in the chat, I'd like one of us to bring it up. I did see a comment from Roger about, there was an effect. I forgot the name of the effect. I want to say the Hawthorne effect, but I don't think that's right. Anyway, and I've learned from patients in diabetic kidney disease trials that even if they didn't get study drug and they found out they were on placebo, that the benefits of trial participation were great because it actually got them to understand their disease better. It got them to understand their blood glucose is better. So there are many benefits in a trial beyond what the actual data show, but just by participating, you're getting more closely monitored. You may have access to standard of care that you don't otherwise have. And again, there's that motivation from the patient is kind of taking more control of their disease journey. So I just wanted to bring that point up from the chat.
Yeah, and I think that was in response to Ali had made the comment of, patients maybe not understanding the potential benefit or seeing a trial as potentially being harmful, and why wouldn't you not just pursue conservative treatment, change immunosuppression, that type of thing. And I think that kind of spun into the conversation on the chat of, patients may do better on clinical trials because of that. But I think that all, and in my experience too, in patients in clinical trials is goes back to that overlying message of understanding the education that the patients are getting about what clinical trials are, because that's that first part of that conversation, right? And so how do we open that door, regardless of what trial it is and what it's for? How do we get our patients to understand why, what it means, and understanding their health literacy of that to be able to best explain it and then make an educated decision about it?
Yeah, I do have to say, I think that there is definitely a stigma in the patient population around the word placebo, especially in the rare disease space. There's a lot of, these patients are coming to you, obviously, a lot of times on a cocktail of drugs. They've tried many, all a combination of such. And so the idea of placebo, I think, is scary because that means no drug. However, in most of these rare disease clinical trials, it's not that there really is a placebo, it's that they receive standard of care. And so I think that's a really important point to make sure that the patient understands that most of these trials, I want to say in IgA, there are some placebos, but they are able to remain on some of their, ACE and ARBs and that sort of thing. So I think it's important to describe that process and probably refrain from using the word placebo because it means that it's a stigmatized word in the patient because it means that they don't get anything, and that's not really true.
Yeah, we really should say placebo / standard of care. And as Jonathan mentioned, in the last couple of years at every conference that we all attend, clinical trials is at the forefront. It's always being discussed. But, what about the meetings where the patients are the audience and attending? And so, I know NephCure started NephCure University where we get on and speak to patients directly. What I see in the kidney community is there's a lot of resources out there, but there's got to be a better way of consolidating. So whatever kidney population you're talking to, whether they're coming from the NephCure database or NKF, we really need like one consistent set of educational tools and addressing things like this. This is what placebo means in a kidney trial and that kind of thing. So maybe that's something we need to think about with all the various societies we're connected with. I do want to mention that the National Kidney Foundation has launched their CKD patient registry, so the first of its kind here in the US. And so part of that effort will be to still, really promote educational and awareness and really zoning in on clinical trials and some of the terminology. Okay, so let's move on to the questions. I'm going to skip around a little bit. This is what I wanted. I wanted the discussion to overtake the flow in the slides, but let's talk about screening. And so for glomerular disease trial, how can screening be simplified? And so the conversations I have with sponsors when we're designing trials is, can you do more effort on the phone? So for example, maybe a phone call to get early consent, even just to do the 24-hour collection, send the jug to the house. When they do their 24-hour collection, by the time they're coming in for their first in-person screening visit, you're already getting their 24-hour urine. And so they may not have to come back a second time in screening. So that's just one idea. So I wanted to hear from the PIs, what have you been able to implement to make screening a little bit more patient-friendly, maybe less visits and so forth? So again, we'll start with Sunil.
Well, at least, providing introductory information about the trial over the phone. So I'll speak to the patients and walk them through kind of where they're at, so they have some better idea kind of what to expect. I think that, this, you had asked another question. I think this branches out into the issue of telehealth and how we can utilize that. I think that these initial visits, especially as I'll outlined, even going through the consent and initial, the screening and participation, I think those could be done remotely. I mean, now with most people are doing a good percentage of telehealth in their office, and so we have secure platforms that work. I think we should be utilizing those to minimize the time travel, and so that, again, makes it easier for the patient to, the first time they come in, the visit isn't necessarily as long, and they can sort of get things moving more quickly.
Yeah, I agree. I think that certainly, I think rethinking our entire process, and that involves, institutional specific processes, processes with the sponsor and the CRO in the way that the protocol is developed, and then most importantly with the patients around how to facilitate screening and actually the entire clinical trial for both recruitment and retention and information is important. I think as we all know all too well right now, that this has sort of opened a Pandora's box with the telehealth. It's a very good thing for many patients. And I think, as describing the geographical barriers to seeing patients with rare diseases and concentrating them at centers that are doing studies, it's a real opportunity. At the same time, many patients don't, now they realize they don't need to come to their center for a lot of their care. This is routine care. This is now not even in the setting of COVID that they may say, well, I was doing the video before, why can't I do it now? It's much more convenient. I don't know about you guys, but for me to go to a dentist appointment is very disruptive. We're all busy, right? Who's going to do that work in the meantime? And, who's going to move my clinic around and all this other stuff? So just think about how disruptive taking that time out of your day would be. But I do think that the screening process of understanding, kind of for the fellows and for people who are not involved, everybody who's involved knows this, but understanding your system of how you're trying to capture that patient population and most effectively engage with them. These things do give us additional tools in order to engage with patients, to get them information, ideas like remote consenting, and certainly removing study visits just to drop off a jug of urine is really nice. There are some things that cannot be moved, right? Some labs need to be done through the central study lab, and until alternative processes were done with local labs to be able to get that done, that is maybe what we may be seeing after the telehealth movement is really taken hold. But I do think that but one thing that cannot be substituted for, I think, is the physician or provider-patient interaction. I think, within the patients that we all have, there are some patients that are ultra motivated. So I can have my coordinator reach out to them. I don't even need to reach out to them, and there'll be buy-in. Other patients, even patients that I have long-standing relationships with, there will be variable buy-in. And I think that the in-person interaction may be important to consider for those patients, but also utilizing all of these techniques, whether telehealth or other things, to figure out how we can just get the information to patients so that they can make the best decisions for themselves utilizing all of these tools. I think it's still very early to figure out how that can be rolled out on a macro level because of all of the different things that, how Suneel's practice work and my practice works is very different. And so how to kind of think about rolling that out on a macro level to get the most bang for our buck, so to say. And also, again, hearing from the patient community about what they would like, also understanding that within that patient community, there's tremendous heterogeneity around, how we all make our decisions around these types of things for these diseases.
Yeah, I'm glad you brought that up, Jonathan, because, not every patient is the same. And I heard from UNC that some patients said, well, it's great to have these telehealth options, but I love going to my nephrologist. And if you offer me I want an option. So we're trying to make our protocols, our schedule of events with a lot of asterisks and say patient has option to choose if they want this to be an inpatient visit versus a home visit or telehealth visit. But with regard to labs, I'd like to ask Jenn, on the design and execution side, we all thought telehealth was like the answer to everything. But then patients started telling us, I don't want a stranger coming to my house. And so the examples I'm thinking of is we were starting to hire home health nurses to come to the patient's house to draw the blood and get the urine samples and do the physical exams. So the patient wouldn't have to travel to the clinic site. And so there was kind of a mixed bag of reaction. And so, and then do you do that during a pandemic? Maybe not so comfortable, but beyond the pandemic when things are more comfortable. So just want to ask you personally, Jenn, how do you feel about if you were part of a study, having that nurse come to your house to do the lab draws, collect a urine and physical exam?
When I first heard about this idea, I was probably in the same camp. I'm like, I don't really know if I want somebody coming to my house. There's a lot of other ways I think that personally I could, especially as a dialysis patient, I draw my own lab. So in my brain, I'm thinking I could just do this at home and send them off. That's not that big of a deal. But the more I thought about it, I probably am more open to it if it does eliminate a study visit. Because I will tell you where I am, a lot of the study visits are like in Iowa or Mayo Clinic. Mayo Clinic's only 90 minutes away, but still it's a 90-minute drive. It's a full day task if you were to drive to Mayo to drop off or to just go do labs. That would be a kind of a waste of time. So if there was an option that lessens the burden or the time commitment on me, I would be available for. I would be up to thinking about it, certainly.
Okay, great.
I think I think this conversation just brings up that there's really no one size fits all, particularly in rare diseases. Really capturing one patient is a big deal. And so understanding that it needs to be a diversified, we're seeing that within our patients, right? As you just mentioned, Barbara, is that, some patients want to come in and some patients don't want to come in. And so understanding that we have to understand how to get these trials done with all of the possible tools that we can, because even within those 3 patients that you enroll in a rare disease trial, each patient will be very different with how they view these tools and how they want to take advantage of them.
Yeah, I agree. I think flexibility is definitely the key. And if that is woven into the fabric of, the design, I think that it's going to be the most ideal for anyone that is interested, obviously, in a trial.
Yeah. And go ahead, Sunil.
I was just going to say, I think like a trial design on all these aspects has not changed much in the years. And so now, as we have better technology, as if we're talking about increasing the the outreach to patients for these trials, we have to become innovative in terms of making them more flexible. We have, I think, we've made it easy for the people right there on site, but for people that are traveling further away and that not only getting aware of the trial, but then participating in the trial, I think becoming more flexible becomes key.
Yeah, I totally agree. Okay, so we've got 10 minutes left and there are more questions to ask, but I see 16 kind of comments in the chat, but I can't open them up. So Dia, is there anything you want to bring up right away for the next few minutes from the chat?
No, I think there's just a lot of commentary on the things that are being discussed about getting, physician and providers involvement and encouragement and support to refer the patients, to show that that's a shift of, that physician cares about that patient and wants what's potentially best for them, and to advance, advance what treatments we have available. Not that it's not a treatment, or don't want to treat them anymore. I think it's more along those lines of how do we shift that, everything you guys have already kind of openly discussed. How do we get the education piece? How do we shift it to, physicians being frontline of promoting this and moving it that way? There was a comment from Dr. Mandayam about availability of trial sites being open, so open on the weekend, so patients can come on a Saturday to do that, where I know at my institution, our research center is not. It's a Monday through Friday thing, so that limits study visits and schedules and things like that, and particularly in a busy medical center where people are coming into town and that type of thing. So I think those are some of the big comments that have come up in there.
Hey, Jen, I'd like to ask Jen a question. I know that your experiences in clinical trials has been widely varied, right? As far as positive and kind of a more negative situation. Could you go into, your experience and, kind of describe what was the big difference between, the good and or not so good? And if you could elaborate maybe a little bit on that, it might highlight some of the areas that, especially in study design or communication with physician, that sort of thing, it might highlight some of those areas.
I had one trial. I mean, most of my trials were all very positive. In the end, I still felt good about them, and obviously still even to this day continue to look for trials. So I guess that speaks that I did have overall positive experience. The one time that I didn't feel very good about it is just I had a study coordinator who was not very organized, didn't communicate. I felt like in the dark, and I felt like with that particular study coordinator, like my effort wasn't appreciated. So that was when you're a patient who's looking for hope and looking to help participate, I think you do expect to feel appreciated. Whether or not that's a big deal for most people, I don't know, but that's, for me, that was what I felt. I did feel too that a lot of the visits, in hindsight, a lot of the visits that I had in person could have been done through telehealth. I mean, most of I never did a trial in my own area. I was always driving 2 to 3 hours to do these in-person drug v placebo trials. So it was not easy. I was working at the time. I had to take days off to do that. And that's not always a possibility for people. Let's see. I guess also overall, what would be nice, and I don't even know if it's possible, but for the people that did participate in the clinical trial, that after that trial was done, if it is, a short-term trial, for us to receive information about how the trial went. There's no follow-up. You just, you participate, you give all your bodily fluids to this study, and then you don't hear anything after it. So you're like, I don't know, was it a good study? Did anything happen from my participation? Was it helpful? I think that's something that's kind of missing in this whole thing, is the full circle follow-up.
I think that's a great point. And I think that there's a lot of patients out there that are willing and interested to be in a trial to further science, because they realize that that some of these will work, and some of them, maybe the drug doesn't advance, but we have succeeded in advancing knowledge in the science, right? So in every way, I think that there is success in every trial. Based on your lived experiences, Jen, can you think back around what were your motivations prior to transplant, looking at some of these trials? What were the motivations that you were faced, that you were encumbering to really go out and seek a trial?
My motivation was, when I first was diagnosed with FSGS and I got on the Google machine and tried to figure out what the heck this meant, I looked at these trials that were, and realized I was diagnosed in 2005, and the trials that I were finding were from 1982. And I was like, well, is no one working on this? Is this really what I'm going to be subjected to? And then when I started doing more digging, I'm like, these are trials with 6 people. Now, to me, you're not going to get anything statistically significant with 6 people. I got very frustrated by what I consider to be a completely stagnant area. So that's when I started digging in and be like, how can I help? Because no one's going to find a cure for my disease if people don't participate. I understood that fairly easily. And that seems to me when we're talking about clinical trials, a lot of people are talking about the fact that you need numbers. You need numbers in order to get these trials funded and to move on through the phases. So I think a lot of people are focusing on that now. But again, like I said earlier too, I had exhausted all of my therapeutic options and nothing was working. I knew that I was going to end up needing a transplant. So I was in a waiting game scenario. So to me, there didn't seem to be a lot of risk in at least trying a clinical trial. I never felt for my situation that any of the trials I participated at put me at any risk. And I know some people do, you know, when I look at Facebook groups talking about clinical trials or other NephCure panels that I participated in, there is concern that they will come into some harm by participating in a placebo versus drug clinical trial. I never felt that way though. I was always like, whatever I can do, let my body be help to science. I can't do anything else about my disease.
Yeah, and I think, you know, to be quite frank and honest, I think Jenn is, you know, she might be some of the exception to the rule, to be honest with you. I mean, we're talking to a highly educated, activated patient who has the knowledge, the skills, and the ability to be able to not only look up information in 2005, and she's seen the gamut of the clinical trial landscape that we're currently in. So she's been when there's nothing to obviously everywhere. But, you know, it poses a question in what and how do we connect with the less activated, right? The less knowledgeable, maybe the less connected patient. And, you know, perhaps part of that goes into, you know, what KHI is going to be doing later this week on looking at increasing diversity, because there's obviously some, you know, aspects around that. So
hey, Kristen, can I just make a comment about the part about the activation? I think there's a danger by saying that Jenn is like, you know, because she's at a certain level of activation that she's most engaged. I'll just tell you from my own experience, I've had people that would be deemed not to be activated, but were very interested in trial. So I think there is a danger by putting people in categories and keeping an open mind, because I've been surprised by people who have been labeled not activated and were very interested. They just didn't know.
Yeah.
I wanted to make one comment, you know, in terms of, you know, I think where Jonathan and I may differ in terms of who we see, you know, we see people that get referred by their primary care physician. They get referred to whatever nephrologist, either the first available appointment they can get, or that person that primary care physician has worked with for many years. And that may be someone who has expertise in glomerular disease, may be someone that doesn't have it at all. And so this is where getting the message out to nephrologists, you know, that are the first point of contact these patients are seeing, getting the message out to them about these clinical trials, I think becomes essential, as well as new nephrologists that are starting, because they're going to be seeing a lot of the new patient referrals as well. And I also think that highlighting what progress we've made is essential, because I do believe, and I talk to my colleagues, that there's a lot of nihilism with regard to nephrology, glomerular disease in particular. So once we start to have a few breakthroughs, we have, you know, the results of DUET, we have the results of the BLISS lupus nephritis trial, we have the DKD studies, we've made in 2 years, you know, leaps and bounds of progress, which I think gets in people's heads. Say, oh, wait, you know, there actually is something new and we are making progress. Maybe we should be, you know, how do we build on this momentum? Because none of us want to be nihilists. None of us want to not, you know, see lack of progress. So, you know, I think that, you know, I can't speak to the patient community itself, which I know Kevin locally in our area has been amazing about getting the word out and getting people interested and refer to trials. But again, back to, most people are going to trust the physician they're seeing, and they trust their physician they're seeing because they've been referred to them by their primary care physician, who they've seen for probably many years. So getting the word out to them, and really that cultural shift that Jonathan has, you know, talked about before, is, I think, the biggest way to impact, you know, widespread, you know, clinical trial successful execution.
Yeah, that's a good point. And Dr. Rodby mentioned that the primary care physician needs to be 100% sold and convinced that this is obviously a good idea as well. I want to follow up with your comment, Dr. Udani, to Jenn. I'm curious, Jenn, how much do you think peer-to-peer communication and how much significance does the peer-to-peer influence take on healthcare decisions, clinical trial activation, that sort of thing?
I guess I don't know about clinical trial activation, but when I look at the Facebook groups that I'm a part of, and there's a lot of communication, like especially if a person has an issue they're not sure about, they're almost always going to throw that question out on the Facebook group before they ask their doctor. It's a little weird. It's a little uncomfortable because a lot of us are like, go talk to your doctor, but they are looking for different experiences. So I think there could be some advantage that you can take of those groups in that kind of setting, because there is quite a bit of peer-to-peer interaction, whether that be, having somebody that's had positive clinical trial experience get on those groups and talk about them in a very open, format, so it doesn't seem like it is coercive. But I have, like I said, a lot of small groups, and I do think there is some value in that peer-to-peer, especially people that have participated, had positive experiences, and understand the value of the clinical trial that could be helpful.
So it's Barbara here, and Jen, I want to go back to your comment about, and part of this peer-to-peer interaction is we have heard, unfortunately, time and again, that we do not do a good job at keeping the patients updated with the study results, and not even at the end of the study. I mean, a study could be 3 to 4 years long, but you're investing all that time. So even every few months of giving patients updates on what's going on with the study. And then even with the results, I ran a patient roundtable, I think last spring. I mentioned some of the positive results coming out in diabetic kidney disease, like the Credence trial, and no one had heard of this. And so here we are, us nephrologists in our society meetings, all applauding these positive results, but we're not getting it down to the patients, because what better way to motivate patients to participate in a trial when they see there have been successes in the last year or two. So, and I think that responsibility comes at 2 levels, both at the PI level, where you did the trial itself, but also at the sponsor level. And so we've had these discussions, and we've asked the sponsor to write up a very quick, brief, patient-friendly kind of summary of the trial results, and not wait for it to get published in a journal that again goes out to the readers, our nephrologists, not necessarily patients, but share this with patients more quickly. And so, and in sharing that update, it's the big thank you and appreciate your time, because what you've invested emotionally and physically in participating in a trial. So that point is not lost on us, and it's something we do talk about across a couple different work streams. And then we're at the top of the hour, we're actually a little past, and I saw something fly by about addressing the elephant in the room, the gaps in ethnicity in our trials. And so I'm just going to take the chance to remind you of the Kidney Health Initiative webinar this Thursday, because the FDA is going to talk about their guidance document and why we need to address these gaps. And then we're going to bring it to kidney disease and have a very practical discussion that includes Dr. Kurt Campbell, Lauren Lee, and Dr. Owen Garrick about how do we address some of these populations who have a lack of trust in medicine and trials and so forth. I mean, we can go on to a whole digression of how COVID and the vaccines and that experience has, I would like to say, prompted a momentum also in trial participation, because I talked to just friends in my community, and now people are asking about how to participate in a vaccine trial. They never thought about clinical trials before. And so there's a real opportunity here that we need to take advantage of. So I just want to thank everyone for their time today. There was a little bit of prep involved, but really this hour of conversation, an hour is not enough to address the things we want to say and talk about. So maybe for a future meeting, we expand this to something bigger. But thank you to Dr. Udani, Dr. Hogan, to Jen for your insights. And thanks again to GlomCon and NephCure for sponsoring these kind of sessions. Really appreciate it. Dia, do you want to have any final words?
No, we can't thank you enough, Jen. Like I said, for joining us, and Kevin for being so supportive and always being on and providing that patient input. That's obviously why we're all here and why we're all doing this, and we need you guys to guide us in it, and to Suneel and John for sharing their input. We will, like Barbara said, we'll be doing more of these. We have another NephCure and GlomCon session coming up in February, so stay tuned for that. And then we'll see everyone who wants to join next week. We'll be back on Sunday with Dr. Glassick, so talking about IgA. So that's all I have. You guys all stay safe and be careful out there.
Yeah.
All
Stay
right.
well. Thank you, everyone.
Thank you.
Well done. Thank you.